So it's now my great pleasure to introduce our first keynote speaker for the symposium, C. Arden Pope III, who is the Mary Lou Fulton Professor of Economics at Brigham Young University, sometimes referred to as the School to the South. Dr. Pope is the recipient of many awards, including an honorary fellow of the American College of Chest Physicians, various other awards, the Utah Governor's Medal for Science and Technology, BYU Distinguished Faculty Lecturer Award in 2006, the Gardner Prize for the Utah Academy of Sciences, Arts, and Letters, the Mercer Joint Prize from the American Association for Aerosol Research and the International Society for Aerosols in Medicine. He is widely described as a pioneer and a leader in seminal studies in air pollution and the health effects of air pollution. And I think while I could go on at some great length to introduce him, I will just say this. As I was organizing this conference and obviously reaching out to some of the nation's leaders on the topic of air quality, repeatedly the comment was, oh, well, so you're in Utah, what you need to do is make sure that Arden Pope comes to speak. And I was pleased by the end of the process to be able to say, he's coming, please join us as well. So please join with me in welcoming Dr. Arden Pope.
Well, thank you for the invitation. I appreciate being here. George told me before I came up here, he says, you're the only thing between us and dinner. Keep it short. So I will. I'm going to skip all of George's studies and move on. So here's a photo of Waterloo Bridge in London, sort of in the background. London's a beautiful place. You can see St. Paul's Cathedral there to the left, and you know the skyline of London. Monet enjoyed London too. This is London, 1903. You can see the smokestacks. We believed, Adam Smith kind of lived close there. He believed there's this magical invisible hand. There's the doctrine of laissez-faire, and what did you do with air pollution? Smelled like money to me. You didn't worry about it. And it was a little bit tricky in London and elsewhere, because it became apparent that it wasn't very pleasant to have really bad pollution. In fact, here's another illustration. This is Gustave Doré. And so this is another photo of what it looked like in the middle of the day. It says, we were well into the morning, and it was as dark as the darkest midnight. It was choking. It made the eyes ache, from this sort of famous book, Pilgrimage, London Illustrations. It's very clear, and I don't need to go through this anymore, but based on Meuse Valley, Belgium, and the episode that occurred in the 1930s, later, the Donora, Pennsylvania, closer to home, so you have Donora here, on this bend of the Monongahela River. You have zinc plants and steel mills and coal-fired barges, and when you ever have an inversion, sort of trap the pollution in the valley, you got really bad air pollution. This is what Donora, Pennsylvania looked like during a real bad inversion. This is at noon, right in the middle of the day. It's really quite amazing. And of course, there were concerns if something like this happened. I mean, there are about 22 deaths, unexpected deaths during this few days of really bad pollution. The concern was if something like this were to happen in a big city, thousands of people would die. And of course, many of you know the story. It happened in London, England. It happened often in London, in fact. But in December 1952, the most famous killer smog episode occurred, and we had, as George showed earlier today, a figure very similar to this, where you had this very, very high increase in air pollution, this very large jump in deaths. And by the way, the deaths didn't really get back to baseline for about 2 weeks, and guess what happened? There were thousands of deaths, probably somewhere between 8,000 and 12,000 deaths associated with this acute episode that occurred in London. So you know, what happened with regards to the doctrine of laissez-faire? We started to lose faith in it, at least when it came to polluting our air and breathing filthy air. And so beginning really in the 1950s through the 1960s, this occurred in the UK, but in the United States, it also occurred. And we had public policy that said, look, we no longer can think the invisible hand is going to somehow deal with our air pollution problems. We do need to have some sort of legislative or at least public policy solution. So, you know, of course, in their early air pollution control acts, there was the Clean Air Act, or at least the amendments of 1970, the establishment of the EPA, and of course, other major amendments to the Clean Air Act that have occurred. And the results have been, we have been getting cleaner air in the United States, no question about it. By the 1980s, in fact, many thought that the air pollution problem had been solved. Now, I don't want to imply that everything changed here in Utah, but at about, George talked about his study. He did some studies, cross-sectional studies across the U.S., and some really excellent work. There was sort of this convergence of research about in the 1980s. Doug Dockery, George Thurston, Joel Schwartz, and others, and myself doing some of the work here in Utah, but others. It's interesting if we come right here to Utah. This is, what did you say, the University to the south? Who was, you know, go south. And what did we have? We had a steel mill. Now, look, we don't let refineries down there, but I'm kidding you. We had Geneva Steel. And Geneva Steel sat right smack in the middle of this great big natural exposure chamber. And all of us that live here in the valleys know what they're like. The valleys on the Wasatch Front really can trap air pollutions during temperature inversions. And we had an interesting natural experiment occur. The steel mill shut down for 13 months and then reopened. And really, I was not involved with air pollution at the time, but I got involved because this was such a fascinating natural experiment. And it became sort of a hobby research project for me that has ruined a good career as an economist and brought me to where I'm at, a disreputable environmental epidemiologist. But basically, we had this steel mill polluting a lot. About 56% of the fine particle pollution was coming from the steel mill, especially during winter inversions. And George, you talked about coming in and seeing that little bit of skiff of pollution in front of this is what it looked like when it was really bad. You couldn't see anything in the valley floors. And some of you have experienced this here in Utah. You couldn't see anything. This is classic smog, combination of smoke and fog. Geneva Steel sits right there. It's operating. You can see these thermal bubbles. I don't even know that's a real word. I made it up. But thermal bubbles are these little bubbles of the hot air coming up out of the smokestacks. Very, very dirty. The question is does breathing that air pollution contribute to ill health? And one of the things we could do very easily is retrospectively get pediatric respiratory hospital admissions for the local hospitals there in Utah County. So we could look at the change in air pollution associated with this natural experiment, this shutting off the pollution, or at least about half the pollution for 13 months and then turning it back on. And what you saw is this really dramatic change in pediatric respiratory hospital admissions. And this was years ago, and there was a couple of studies done on this, published in good journals, and these results have held up quite well, even though controversial at the time. There's another way here in our Utah valleys to think of experimentally looking at what happens with air pollution, because the other thing that happens is we put a lid, or at least nature puts a lid on our valley, doesn't it? So we get these temperature inversions where the air pollution's trapped on the valley floor, and the concentrations build up, and then a cold front comes through or whatever, and it's lifted, and it cleans up again. We'll have beautiful, clean days. And so as a result of those sort of natural experiments, if you will, that come from these temperature inversions, we get this very, very dramatic changes in air pollution. along the Wasatch Front, there's no question that many of our days are very beautiful, very clean, but there are many days where you get like this, where are very dirty and highly polluted. And then the question is can we look at some adverse health effect and see if it's associated with day-to-day changes in air pollution? And I'm thinking of one adverse health effect that's pretty bad. What would that be? Death, right? Let's just look at dead bodies, shall we? All right. So we count the number of dead bodies that occur every day, and we come up with these daily death counts. And so on some days, nobody dies. This is Utah Valley. Nobody dies some days. Some days, one person dies. Some days, two people die. Now, you're looking at a lot of what statisticians would call Poissonian variability. We understand that a lot of that variability just comes from the process of generating counts. But we can also sort of peer through that Poissonian variability and try to see if there's any structure associated with air pollution. And in fact, there is. One of the easiest ways to see that structure is just simply take these counts and divide them up into days of different levels of pollution, so just quartiles of air pollution, doing nothing fancy statistically here. So just simply plotting the average death per day across the quartiles of air pollution. So you can see there's this positive, monotonic, near linear exposure-response relationship by doing nothing more than sorting deaths across different levels of air pollution. Pretty amazing, isn't it? Now, we could criticize this result and say, well, there's other things going on, so we may want to model it in a more sophisticated way. We can take this Poisson process, we can do a Poisson regression, we can look at lag structures, we can go into lots of complicated stuff, but I can say that you can basically do this. You can look at daily mortality counts, regress them on air pollution, controlling for temperature, relative humidity, seasonality, various other long-term time trends. And what you get is you get a phenomena that can be observed not only here in Utah, but in basically every city in the world where this has been studied. Day-to-day changes in fine particle air pollution is associated with small but perceptible and important changes in risk of dying. All right? Now, you may want to do something a bit more sophisticated than just looking at death counts. Here's a study that we did, again, here, most of these patients are in the Salt Lake area. We had about 13,000 well-defined and followed-up cardiac patients who lived on Utah's Wasatch Front. And what's nice is that we had angiography on all of them, so we could actually look to see whether they had diseased coronary arteries, and we had, of course, a lot of other medical information. And again, without going into the details on sort of how we analyze these data, I can say in the end what we learned is that if you went through a period of 1 or 2 or 3 days or up to 5 days of elevated air pollution, like happens here all the time, right, during these air pollution episodes, when you have an air pollution episode, every 10 micrograms per cubic meter increase in PM2.5 increased the risk of having an ischemic heart disease event, primarily a heart attack or related ischemic heart disease events. It increased the risk of having one of those by about 5% per 10 micrograms per cubic meter increase in PM2.5. And what was particularly interesting about that is that for this short-term exposure, that is exposure for only a period of a few days, it only elevated the risk in those that already had vessels that were diseased, that had underlying coronary artery disease. Very consistent with what you might expect to be the case. Now, we don't have a lot of time here tonight. George wants to go eat dinner, all right? So I'm going to skip over a whole mass of literature that demonstrates that short-term, that is day-to-day changes in air pollution, are associated with day-to-day changes in various health outcomes, such as death, hospitalizations, lung function. George mentioned this actually isn't a short-term study exactly, but this absolutely amazing study out of the Southern California Children's Health Study. Now, they've published a number of papers about this. Dr. Canner probably knows this research better than I do, but a number of papers out of the out of the California Children's Health Study. Did you see the one just today in New England Journal of Medicine? Just saw the summary, yeah. That's all I saw too. But it looks like it's lung function growth, symptoms of respiratory illnesses, school absences, ischemic heart disease events that I just mentioned. Day-to-day changes and exposure to air pollution are associated with day-to-day changes, changes in adverse health outcomes. Now, if that's true, what do you think happens if you have long-term chronic exposure or repeated exposures to air pollution over a period of years? What'd you say? You're dead faster. Let's go eat, George. We're done. Good answer. So, we've known for some time, ever since Lester Lave and others, including some of George's work in the 70s and 80s, we've known for some time that adjusted mortality rates, so if you take age, sex, race adjusted mortality rates across communities in the United States, that you see higher mortality rates in communities with higher levels of fine particle air pollution. One of the interesting things about that study that George mentioned is he focused a little bit more on exactly what sources of pollution were contributing mostly to this. And again, it was combustion-related pollution especially, but even more particularly, as I remember, it was coal combustion that was particularly responsible for this relationship. Now, one of the more famous of the studies is what's often called the Harvard Six Cities study. This is a little different design. What it does is it enrolls cohorts of people and follows them over long periods of time. And so it's looking at different, in this case, people that live in 6 different cities with different levels of air pollution, and then monitors the level of air pollution, follows them up for a long period of time, and sees how long it does take them to die. That's the design of the study. They're very frustrating studies. If you're an old guy that's already developed a reputation and you can get the money to do one of these studies, what happens? You die before your cohort. And if you're a young guy, you can't get the money. So it turns out that these studies tend to be somewhat intergenerational. Okay. So Ben Ferris and Frank Spicer sort of started up these studies. Doug Dockery, myself, and others have been able to sort of follow up. Although the younger generation, I'll admit, we're getting old. But the bottom line is we follow this. I'll just show you how the study's sort of designed. You have 6 different cities, 2 that are relatively clean, Topeka, Kansas, and Portage, Wisconsin, 2 that are relatively dirty, Steubenville, Ohio, and St. Louis, Missouri, and then a couple of cities kind of in the middle, Kingston, Harriman, Tennessee, and Watertown, Massachusetts. On the horizontal axes here, this is the follow-up years. On the vertical axes, this is the proportion of the people that are alive. You can see at time naught, the time of enrollment, everybody is alive. That was a condition of enrollment, okay? Yeah. And you can see these curves are sort of splayed out, aren't they? So there's no games going on here. You're looking at basically the raw data. That's the more polluted cities, you can see people are dying more rapidly than those in the cleaner cities. Now, we actually want to do a better job of analyzing these data and model them so you're controlling for differences in age, sex, race, cigarette smoking history, this sort of thing, right? So we're going to do that, with one of the most elegant models ever presented. You love it, don't you? This is called the Cox Proportional Hazard Regression Model that allows us now to analyze the relationship between various risk factors, controlling for other risk factors, to see if you control for these other things, you actually see an increase in mortality associated, in this case, with air pollution. So this is sort of the results of this, from this Cox Proportional Hazard Model. We represent the results often with what's called risk ratios or hazard ratios. And I'm just showing you for cigarette smoking right here, this 2 means that you have a 100% increased risk, or a 2 times increased risk of dying if you're a smoker versus a never smoker. Now, we all are going to die. But what this means, this is a condition, this is the risk of dying on any given time period conditional upon living to that time period. All right? So we know we're going to die, we just don't want to die today, right? And so that's the kind of, it says your risk of dying on any given day is 100% higher or twice as high. What does this say about smoking? It's kind of not very good for you, right? And it's a dumb way to die, too, by the way. Pneumonia, pleurisy, emphysema, lung cancer, heart disease. There's better ways to kill yourself than smoking, okay? Now, what about air pollution? Well, it turns out that we got this result with air pollution, a 1.26 risk ratio. Now, that's not nearly as big as cigarette smoking, is it? But it was stunningly large. It's still surprising. If you think about it, how many people in a community, back then in Steubenville, how many people smoked? About 25, 26% smoked. How many of the people breathed? About 100%. And in fact, the very simple arithmetic suggests that the attributable mortality to air pollution was roughly the same as the attributable mortality to cigarette smoking. Not because cigarette smoking wasn't much worse, it clearly is, but because the exposure to air pollution was ubiquitous. Now, if you look at these rate ratios sort of across, not just across the full range of pollution like I showed in that figure, or in that table, but if you look at it sort of plotted over different levels of air pollution, so these are the cleaner cities, the more polluted cities, you get this relationship that looks like what? Well, it looks like we cheated. It's really remarkable. We didn't. This is what it actually looked like. Pretty amazing. And in fact, these results actually led us to another study that George has already shown. He looked younger then than now, but so did I. The bottom line is the Harvard Six Cities study directly led us to another cohort to see if we could get the same results in an independently collected cohort. It was called the American Cancer Society Cancer Prevention 2 cohort. And so we did several studies using this cohort, and George has already shown a figure that looks basically like this. But the bottom line is that the Harvard Six Cities study and the ACS study both observed that roughly similar results, that as you increase exposure to air pollution, you, at least in long-term exposure to air pollution, you see increased risk of early mortality or early death, as you have already stated. Now, you'd think that this would have been important news, and I think it was important news, but there was a lot of pushback. And the title of this talk had something to do with the science and the controversies, right, and public policy. There was a lot of pushback. And in fact, the industry and environmental researchers are squaring off. This was a 1997 article in Science, are squaring off over studies linking air pollution and illness in what some are calling the biggest environmental fight of the decade. In fact, what happened is there was so much criticism, or at least concern about these studies, and requests to have them reanalyzed, that we actually turned the analytic data files over to an independent research group of about 31 researchers, and they actually had a dedicated computer and spent about 3 years doing this reanalysis. And in the year 2000, July 2000, the results of the reanalysis came out in the Health Effects Institute report, and in essence, they got the same results that were reported earlier. And they did a lot of sensitivity analysis as well, and the results were actually even more robust than I would have even imagined. Now, it seems like earlier, I just caught the tail end of a talk. You've already talked about this court hearing, right? I mean, there was also this legal wrangling. There were lawsuits, and I'm not an attorney, but the bottom line is that the legal uncertainty with regards to the standards based on those and other studies was largely, although not entirely, resolved with a 2001 unanimous ruling by the Supreme Court. And I'm sure there's more others in this room that can discuss that better than me. Now, again, I'm going to have to just skip an enormous amount of literature. After a while, it became very apparent from the straight-up epidemiology that air pollution was associated with adverse health outcomes, especially as they related to respiratory disease and cardiovascular disease. All right? Now, one of the most important things to do, I think, to really reduce the uncertainty with regards to whether these associations are causal, is to sort of try to look at biological pathways or biological mechanisms that would explain the link between exposure to air pollution and the adverse health outcomes that we observe. And we've done a lot of this work. Dr. Cantor and I did some work together looking, how long has that been now? A long time. And maybe not you, but I was really naive. I thought back then it was all lung function, right? And lung function does seem to play a role, but it's clearly not all lung function. And so over the years, we've been looking at a number of different health outcomes, but specifically various subclinical responses to air pollution. And then there's been a number of controlled human studies and toxicology studies. And there's been this increasing understanding that being exposed to air pollution clearly contributes to ill effects in the lungs. But there are also these sometimes we'll call systemic or spillover effects, where you get effects in the blood, in the vasculature. You get, it contributes to atherosclerosis and various atherosclerotic-related diseases. We see changes in the central nervous system. We certainly see changes in the heart, and it'd be fun to talk about some of these. But there's even quite a lot of studies recently that have looked at cardiac function, cardiac autonomic function, and our heart's ability to control its rhythm. And while this literature is complicated and not fully understood, there now is clear sort of evidence of biological plausibility of the epidemiologic associations that I've already shown you. This has been mentioned before. The Global Burden of Disease report that just came out, well, it's been out a couple years, I guess now, but it turns out that it's no longer surprising that breathing toxins or breathing toxic material is not good for our health. And if you look at the 10 most important factors that influence, the burden of disease, 3 of them are really just breathing toxics. Tobacco smoking, which is absolutely clearly unhealthy. Indoor household air pollution from solid fuels, not such a big deal in the United States, although I understand there's some debate here about wood smoke, right? But in some countries, this is a huge deal, right? You just have to feel for these poor mothers that have a child on their back, or they're tending children in a small place where they're cooking on a 3-stone stove or heating their home in a poorly vented stove using charcoal or wood or often even dried animal dung. The exposures can be high, and the impact on their health can be substantial. And of course, air pollution, ambient air pollution is important as well. And this has been mentioned before. We're talking somewhere in the neighborhood of 3 to 7 million people, depending upon how much double counting and how big this is. But it is a substantial contribution to burden of disease. So then the question you might ask is, Well, in the United States, our attempts to reduce pollution have been helpful. We've reduced pollution in many areas in the U.S. Has that been substantial enough such that we can actually see improvements in human health? And the answer to that is yes. Let's go back to the old. I wasn't part of this reanalysis or this extended analysis, but Francine Layden, Joel Schwartz, and their colleagues actually did an extended follow-up of the Harvard Six Cities study of another 8 years. And what was nice is in those 8 years, things really cleaned up a lot in a number of the cities. In fact, cleaned up in every city. And what they did is they looked to see, oh, wow, look at Steubenville. It really cleaned up. And they're adjusting for other factors. There was this big drop in the risk of dying. Same thing with Kingston-Harriman. In fact, in every one of the cities, even the two clean cities that cleaned up somewhat, the adjusted rate ratio or mortality rate risk ratio actually went down. Stunning. Doug Dockery, Majid Azadi, and I did a study a few years ago where we said, let's use this great big natural experiment that has occurred in the United States, where we had the Clean Air Act, and we had really what motivated a lot of cities to clean up quite a bit, okay? So we had a lot of cleanup in the United States, but some cities cleaned up a lot more than others. So we have this sort of differential reduction in air pollution, and we want to know if that differential reduction in air pollution was associated with a differential increase in life expectancy, controlling for socioeconomic, demographic, and smoking factors, all right? So the answer was yes. It turned out that for every 10 micrograms per cubic meter decrease in long-term average PM 2.5 concentrations, there was about a 7-month increase in life expectancy. Colbert said, wow, you could watch a whole season of Ghost Whisperers. He wasn't that impressed. But think about it for a minute. What can we do? What sort of medical interventions did we have over that 20 years that would have given us a bigger increase in life expectancy? Very few. Reductions in smoking helped, no doubt about it. In fact, probably had a bigger impact. Reduction in smoking that occurred during that time frame. There was also the introduction of maybe statins might have had a really big impact. But that's, I don't know. It's pretty hard to find any other medical intervention that had a bigger impact than just the efforts to improve our air quality in the United States. Well, this ought to be great news, right? This ought to be just fantastic news. Well, not so. Last year, or a year or so ago, our buddy Chris Stewart and Lamar Smith said, oh, this is all secret science. And they actually subpoenaed the EPA to try to force them to release the secret science that it uses to do its costly regulations. What did it subpoena? All of the data in the Harvard Six Cities and ACS studies, including all analysis and reanalyses. And it also interestingly enough, subpoenaed this study that has no confidential data and has been made public a long time ago. So that was easy. We just sent it to them. But let's talk about these two studies again that were subpoenaed. Remember the Harvard Six Cities study? Originally, I think you were at Harvard when we were doing this, weren't you, George? It seems like at that time we said we didn't even want to send this paper out until we could reproduce it in another study. And so we did. That's why we went to the American Cancer Society. And we had these two independent studies, or at least independent in terms of the data. Clearly there was some of us did analyses on both of them. And published them. Of course, I don't know how secret it is to publish in the New England Journal of Medicine, but it is true. I'll have to admit they did play an important role in motivating and developing public health and environmental policy. And so it's understandable that there'd be requests for independent analysis. I'm okay with that. That makes sense to me. I mean, there can be substantial benefits from verifying the validity of research through independent reanalysis, replication, and extended analyses. And this is especially true, and we have been talking about some of the economics of this already, and there are big stakes involved, aren't there? So it's especially true when there are large economic and public health implications and ramifications. The dilemma, of course, is that these studies use private and personal data collected under ethically and legally binding confidentiality agreements with regards to the research subjects. It's simply ethically and legally wrong to turn over the raw data to these studies. But that's not to say we can't try to have independent analyses. Let me just remind you of what I said before. The Harvard Six Cities study motivated the ACS study, and only with replication were these originally published. But then there was this independent reanalysis of the Harvard Six Cities and ACS studies. They were published in peer-reviewed reports, the Krusky et al. HEI report, and then a series of papers in the Journal of Toxicology and Environmental Health. Remember, there was this 3-year reanalysis by a team of 31 independent researchers with oversight from a 9-member expert panel, and a peer review by a special panel of the HEI Health Review Committee. It included full data access that ensured the privacy and confidentiality of research participants, and the reanalyses included data audits, full replication and validation, and an extensive sensitivity analyses. I apologize for the format problems with PowerPoint. In addition to these reanalyses, independent reanalyses, there was extended analyses. I've already mentioned the one, that was the Francine Layden paper with the extended analyses. There's been 2 others of the Harvard Six Cities study. With the American Cancer Society study, there's now been about 10 extended analyses. Now again, all of these are published in top places: Journal of the American Medical Association, Circulation, Epidemiology, New England Journal of Medicine, Lancet. These are the top peer-reviewed medical journals available to publish in. Now, what's probably even more important is that there have been a number of studies that have used completely independent cohorts and analyzed them, and completely different research teams in many cases. So, for example, there's Miller et al. At University of Washington. They did an analysis of the Women's Health Initiative cohort. There's a study out of the Netherlands. There's an interesting study called the U.S. National Medicare Cohort, Nurses Health Study, Health Professional Study, U.S. Trucker Study. Earlier today, the Canadian study out of Canada has already been mentioned, a study out of Rome. This big meta-analytic study using 22 European cohorts recently published in The Lancet. This is the way science is supposed to work. You replicate the work, but you don't just reanalyze the same data all the time. That's important to do now and then to make sure it's right. But you want to replicate the analyses, and these analyses now have been replicated multiple times. And I'm fully aware of another paper that's been submitted with another cohort that'll be interesting when and if it comes out. Still, there are some that assert that these are secret science. Now, you don't believe that, do you? That can't be true. Well, probably tomorrow, they're going to vote on a bill called the Secret Science Reform Act of 2015. This bill prohibits the EPA from taking any action. That means risk exposure or a hazard assessment or criteria documents or standards or limitations, regulations, any action, unless all the scientific and technical information is, and I'm just reading, this is basically the text of the bill. It has to be the best available science has to specifically be identified and publicly available online. It requires public availability of all materials, data, associated protocols, computer codes and models, recorded factual materials, and detailed descriptions of how to use such information. All right? Now, this actually, it seems reasonable enough that we ought to have transparency, right? But I don't know myself whether if this Secret Science Reform Act is just simplistic and naive and unbalanced between, looking at the privacy versus public access issue, or if it's really designed to be a catch-22. Let me just read the Secret Science Act in the way, in essence, that it is, what it does. What does it do? It mandates the EPA use the best available science. Then it prohibits the EPA from using the best available human science or human studies that analyze clinical data, longitudinal cohort data, and various other studies that use personal confidential data, unless those data are made publicly available online, even when this would violate ethical and legal confidentiality restrictions regarding the personal health data. You decide. And that wasn't nice. I don't want to agree in public. But, I mean, the truth is, I don't know. I think, I mean, this would be cuckoo, right? This might be shrewd. I don't know. I mean, I don't know for sure. Just to give another example, and I gave one example of one of these studies, but I work with a lot of people doing research all the time, and I'm always getting approval from institutional review boards to do studies on human subjects, and I also work a lot with various with clinical data, and one of the best partners for me over the years has been Intermountain Healthcare, and I've had the opportunity to collaborate with excellent researchers from the Intermountain Medical Center, from BYU, from the University of Utah Medical School, evaluating the effects of air pollution on various things. And these have all been published in top journals. But it has to be understood that there are always data use agreements that require compliance with institutional review boards. There's the HIPAA and other applicable laws that restrict what we do with these data. There's almost always restrictions to specific, to only use the data for specific research purposes, et cetera. And in fact, a recent agreement that I did, is this normal now? The latest data access agreement required a $5 million insurance policy before we could to protect the data. Maybe it's lower for others, but for me, it was $5 million. It seems a bit high. It's just simply the reality that releasing these data would be illegal and unethical. And this is just an example. There are many, many, many important studies that use these kind of data. Now, I'm going to close with the two biggest criticisms of these studies that we hear all the time, or used to hear. Number one, the effects aren't big enough to be compelling. You have to have risk ratios of 2. I'll just say up front, that is stupid, okay? There are very few things that give you risk ratios of 2 or better. Cigarette smoking is one of them, all right? Stepping out in front of a bus going 100 miles an hour is another one, all right? But there are very few that give you risk ratios. If you start, it's crazy. So what's the second biggest criticism? The effects are just too large to be biologically plausible. I know. This one actually makes a bit more sense, however. Let's just look at this one for a minute. if you smoke a pack of cigarettes a day, you're exposing your lungs to about 240 milligrams, not micrograms, but milligrams of fine particles. Now, the excess risk of cardiopulmonary mortality will be roughly about 2, all right? If you are living in a home where you have a spouse that smokes or you work in a smoky environment, your excess risk is about that high, about a 25-30% excess risk. But the exposure is so tiny, it looks like I've plotted that on the vertical axis, right? A similar thing with regards to air pollution. The excess risk is pretty high. It is actually way higher than what you would expect based on this linear extrapolation from smoking. So what does this mean? Well, it means, I don't know what it means. It means either this is way more toxic or this exposure response function is not linear, right? So working with colleagues at the American Cancer Society and elsewhere, we actually took all of the data. I don't have time to explain exactly what we did here, but we took data from the ACS and we actually calculated the excess risk from smoking different levels of cigarette smoking. So this is less than 3 cigarettes per day, 4 to 7 cigarettes per day, 8 to 12. And so on this horizontal axis, you have 2 scales. One is the number of cigarettes per day, and the other is the estimated daily dose of PM2.5. And then you look over here, and from different studies, you have the excess exposure from air pollution and secondhand smoke, and the excess risk. And again, it looks like it's almost on the vertical axis, doesn't it? Wow. The other thing that you can see, and I don't know, log scale. That is it. That's exactly, it's the same plot, but on the log scale. Is there anything magical about linear or log linear for that matter? Okay. But on a log scale, this fits pretty good, doesn't it? It fits pretty good. And I look at that, and that's got to be one of the prettiest figures I've ever seen. We did this analysis again, so this is looking at non-malignant respiratory and cardiovascular disease. We wanted to ask ourselves, would we see the same thing with lung cancer? So this is basically just a reproduction of what I showed you before, but with an extended data set and pulling it out farther. We get the same results. But with lung cancer, we don't get the same results. With lung cancer, as exposure goes up, what happens? Excess risk just keeps going up and up and up and up. It's absolutely amazing. Stunning. At the highest level of smoking, you get adjusted relative risks of 40. Unbelievable. But there's something going on with these non-malignant sort of, respiratory and cardiovascular disease. There seems to be this well, I don't know what it is. It's sort of a saturation phenomenon that's going on. And if you believe the inflammation hypothesis, it does make some sense. And in fact, it helps explain the secondhand smoke literature as well. But we don't know it entirely. Thank you. I'm done.